start with a roll call. Cindy, Maria,
Here.
Valerie Hutchinson,
Here.
Valerie Mincy, Samuel Carter, Naya Sylvia,
Here.
Leroy, Shane,
Present.
Amber, Bobby's here, Delina, Bernadette, Janet, Jim, Harris,
Here.
John Curry, John Acevedo,
Here.
Clark,
Acevedo, say it right now.
Clark, Eric,
Here.
Sandra,
Here.
Julia,
Here.
Donna Markland, Joshua, Felicia, Charles Martin's here, Calinthia, Buell, Derek,
Here.
Laverne, Dina, Eric Martinez, Cynthia, Jeff, Ken Barger's here, Daniel,
Here.
Marlinda, Philip. We have enough for a quorum?
Yes, we do.
Maybe on 12. Okay, we've had roll call. We're going for the welcomes now. And I'll start. My name is Bobby Davis. I'm the public health co-chair, and I'm from the Gainesville area.
My name is Charles Martin. I'm the community co-chair, and I'm from 11A, Miami.
Maria Thompson, Shake from Florida, Area 1. Naya Hubbard, Florida, Area 7.
Shane Bailey, area 313.
Jim Barger, PPG rep. Jim Roth, Public Health Rep, Area 5614.
I'm Derek Trailer, I'm from Key West, Area 11B.
John Acevedo, Community Aids Network, area 877.
Cynthia Poitier, Prevention Rep, Area 15.
That's Cynthia. I'm sorry. Let me, cause we got some new people in here, so when we say the areas, could you say what part of the state they are as well, please? And I know you weren't the first one to do that, I'm just.
Area 15, Martin, St. Lucie, Indian River, and Okeechobee counties.
Justice Minister Prevention Rep Area 4, Duval, Clay, Baker, St. Charles. And that's all. Yeah.
Dan Merkin, Behavioral Science at Large.
Valerie Hutchinson, Area 2A Prevention Alternate, A. Jackson, Calhoun, Holmes, and Washington County.
Sandra White, Area 9,
Juliet Love, Area 10, which is Broward County.
James?
Community Rep.
James? James?
Tally, James Tally, Area 1, West County.
Evelyn Morales, Broward County Health Department Prevention Program Manager, Area 10.
Paymo Nguyen, Doctor of Operations at SOBAP, Miami Beach.
Good afternoon, Evelyn Mula, Area 10, Broward County, incoming DOH rep.
Keith Ford, incoming alternate DOH rep for areas 5, 6, and 14. That's Pinellas, Pasco, Hillsborough, Manatee, Polk Hart, and Highlands County. And I may have left one out though.
Robert Morosi, Program Manager, Manatee County Health Department, Area 6.
Good afternoon, Kathleen Jean, Area 5, Pinellas County Health Department.
Good afternoon, Crystal Payne, Palm Beach County Health Department, Area 9.
Michael Rupel, the AIDS Institute.
Allison Herring, Bureau of AIDS.
Dawn Hunter, the AIDS Institute. Michelle Skabnicki, staff support with the AIDS Institute.
Hi, Marlene Lalota, HIV Prevention Director at the Bureau of HIV/AIDS.
Hi, Brother Nathaniel Henley, Northeast World AIDS Network, the incoming at large representative.
And Ted Howard with the AIDS Institute. Thank you. Sticking with the agenda, our next thing is the minutes from the November meeting. It's about the third one back on the right-hand side of your packet. I ask you to review those.
Motion to approve.
We have a motion and a second. We'll give people a minute to review them. Do we have any discussion about the minutes? All in favor?
Aye.
That's a ask. Yeah, okay. All opposed? Motion, minutes approved. The next thing on our agenda is the, a moment of silence, please, for those that are affected, for those we've lost. Thank you.
All right, so let me start with some of the things happening at the Bureau, what I know, anyway, to be true as of today. For those of you who don't know, Tom Liberty's going to try to make it in this afternoon. He's in town, and he said he was going to try to stop by in a little bit, so he may want to address some of the stuff that's happening at the federal level. It's a stressful time for all of us, as you know, and I think it's stressful not so much because there could be some bad things coming. It's stressful because of the waiting. It's been very frustrating for us. We're waiting for budgets to get resolved at the state level. We're waiting for budgets to get resolved at the federal level. The federal government is very dangerously close to a complete shutdown Friday night, tomorrow night at midnight. If there is not an agreement, the federal government will shut down. What that means for us really is not a whole lot. It means less conference calls and emails, so that could be a good thing. But in terms of the prevention work that we do, it's not going to stop that. We had received 25% of our grant on January 1st. That money ran out March 31st. And then we have a letter from them promising another 25%. So even though that money's not in the bank yet, we have a promise so that we have enough money to keep going in the prevention program through June 30th. We're hoping that they don't have a shutdown. We're hoping that there's a resolution so we can know what we're dealing with. What our biggest concern is that every time they do this continuing resolution, they cut billions of dollars from the federal budget. And eventually, some of that could potentially trickle down to HIV/AIDS work. It hasn't so far in the first round of cuts, but what they're talking about now are pretty serious, 33 billion, 40 billion, I guess it depends on what they end up with. Those cuts could very well trickle down into CDC and then into HIV and STD and other public health work. So the really bad scenario would be that they come to an agreement and then they decide that we have to take a big cut, and if that cut goes into effect, sometime in April or May or even June, then that cut will have to be absorbed between now and the end of the calendar year. So we won't have a whole year to spread the cut, so that could make it more painful. So what we've been doing to be proactive is certain positions are being held open in the field and at headquarters. We are not purchasing anything from the prevention grant in particular. No incentive items, no promotional items. Really just bare bones, things like rapid test kits, the condom orders. But other than that, that's it. We're really, really holding back on buying things in case there is a cut, so we don't have to, you know, cut positions. At the state level, we do anticipate some cuts to our budget. We don't know yet how big those are going to be. What's proposed right now for prevention is a line item that's been in the budget for a number of years. That was what they call a turkey project, which means a special member project that was put in our budget years ago to do what they called Haitian and Hispanic outreach. It's $239,000, and that's slated to be cut. That money is spread across 3 contracts that we fund. So if we lose that money, what that means is those contracts will end at the end of December instead of getting a new contract like the other prevention projects.
Is that the only funding for the Haitian communities across the state? I'm just curious.
No, it's not. It was just in that special category, so we just spread it across projects that happen to reach Haitians and Hispanics, but it won't be the end of Haitian work that we do in Florida. And then closing the gap is not completely finalized. We talked a lot about that at the last meeting in November. Tom may want to say a little bit about that. The plan right now is to move forward with cutting the projects, the 5 projects that we talked about at the last meeting, and I do believe that that is what's going to happen. And really, the contracts won't be ended, they just won't be renewed come July 1st. So Tom can talk a little bit more about that when he gets here, because it's tied in very heavily to the ADAP crisis, which, by the way, is still a crisis. Even though we made it to April 1st, which was the key deadline, the Well Vista plan, it doesn't mean that we're out of the woods in ADAP. You know, if dramatic changes aren't made to the program, we'll be right back where we are, you know, in less than a year from now. So that crisis is far from over. So the other thing that happened up in Tallahassee, bless you, Bobby, is that they want to reorganize the Department of Health, and this has been going on for several months now. There's a number of competing plans. One plan actually merges us with several other state agencies. That seems to have kind of cooled off a little bit. That doesn't seem to be a leading contender anymore. The governor did appoint a new secretary/surgeon general for us, Dr. Frank Farmer, who started on the job Monday of this week. His resume, if you just Google Dr. Frank Farmer, you'll get his resume comes up, and it's just unbelievably impressive. He's very accomplished both in his medical career and his military career. He was president of the FMA for a while. He's got a very impressive list of credentials. He also supports the governor and the governor's positions on things like healthcare reform, for example. So, but he does seem passionate about public health and medicine, so maybe we'll get a more, balanced approach. So the plan has been put forth to reorganize the Department of Health. It was approved by the governor's office. It was pretty warmly received by the legislature. And so what we're thinking now, the fact that they appointed a secretary for Department of Health and for ACA, the thinking is that there is, at least for this year, they're probably going to leave us alone and let us reorganize ourselves to be much smaller, much more streamlined. I think we're going to look different at the end of the day, the whole department. There's a lot of programs in the department that are listed for either elimination or transfer to somewhere else, to another department where it makes sense for that program to be. But there's a lot of programs and a lot of positions that are going to be eliminated from the Department of Health. And our division in our bureau is not immune. We will be taking cuts in the prevention section. It might be one position, it might be two positions. And we don't think it's going to be more than two positions. I'm hoping it's only one, because that's all that we're keeping vacant. But we will have cuts in the bureau, and probably every single section of the bureau there will be cuts, whether they're filled or not, is the instructions we got. They are also looking very hard at regional positions. And I suspect that the way regional positions operate on a day-to-day basis will be redefined or further clarified. I don't think regional positions are gonna go away. That's just me, my gut feeling. But I do think that there will be probably a little more accountability, a little more day-to-day contact with each of the health directors in the counties that the regional positions cover, and maybe some other types of accountability measures built in. So we are in the process of filling 4 positions in the prevention section. One is a counseling and testing field rep. Brandy Williams went to Atlanta to work for Alicia. Some of you may remember her. She's stealing all our people. She took Brandy. So that position is in the process of routing for approval. Kenneth Johnson, she took him. That is the position we're leaving vacant, so we may not be able to fill that one if we lose it. Dan O'Beck left to move to Portland, Oregon, which is where he's wanted to live for a long time. That process, that position is in the process of being filled. It hasn't been signed yet, so I can't say the name of the person. She will be the behavioral surveillance coordinator, working in Miami in behavioral surveillance. She is bilingual, I can say that, and she has a really nice, very impressive background. Then April is in the process of hiring a mobilization coordinator, specialist type position, and that person should be here hopefully in a couple weeks. And then finally, I have a position that I've really retooled. It used to be our evaluation coordinator, and Alicia TAI was in that position, and she left to go to nursing school. She got accepted to the accelerated nursing school program at FSU, which is a really prestigious program, and you have to go full time or you just, you wash out. So she had to stop working to go to school. So what I'm doing with that position is it's going to do 2 or 3 main functions, but one of the biggest functions is to coordinate MSM activities for us, and not in an on-the-ground kind of way, like the way Lorenzo does, for example, but more in a big picture kind of way. One of the other big functions is to do some strategic planning and some policy development, and in particular, working with the National AIDS Strategy and ensuring that all of our programs are aligned with the AIDS Strategy. And there's a lot of work to do around, around aligning us with the AIDS Strategy, around new prevention technologies, things like PrEP and PEP and needle exchange, and all these new policy issues that come out all the time. So this person will work on some of those issues for us, developing white papers, and helping to guide us based on national policy and what some other states are doing and things like that. And really making sure that all of our prevention activities are aligned with the AIDS strategy, and in particular that our activities are targeted and focused where the epidemic is. And that means geographically, that means by race, ethnicity, by risk, really working on ensuring that we move to, have all of our resources aligned with all of these different things going on at the federal level. And the other big thing that's hanging over our heads is the competitive prevention grant for 2012. So we will be applying for that sometime later this year. The funding announcement has been delayed, is what we heard. It's supposed to be out in May now, which means we'll be writing probably in May, June, maybe even into July, depending on when it comes out. And so we really want to make sure that all of the strategies and activities in there are aligned with not only the AIDS strategy, but the recommendations from our various advisory groups, recommendations that have come from national groups. There's a lot of moving parts and pieces, and some days it gets hard to keep up with it all, but we want to make sure that our programs are cutting edge, that they're cost effective, that we're getting the most bang for the buck, that we're not doing things that don't work anymore, or that just aren't having enough reach. We want to make sure that we're implementing interventions that are scalable. So all of those things, you know, that's a really huge job, and I'm really excited about the person that I've found. The paperwork hasn't gone through yet, but I think she's going to do a really good job. So that's lots of personnel type stuff going on. Are there any questions? I'll just pause there for a second because I know that's a big mouthful. Everybody good with?
No, I got a couple questions.
Yes, go ahead.
You said, when you were talking about the cuts in prevention, you were talking about people, and I don't want to sound callous because I'm not making light of that. I'm just wondering, are you talking about programs as well, or just people? And when I say just people, I don't mean to.
I know what you mean. No, what would happen realistically is that we would lose 1 or 2 positions, and then the rest of us would absorb the workload. That's what that means.
Bless your heart. And the other question was, the person that you were talking about, you talked about a position, and you were talking about MSM program. They would do MSM program. Is that going to be their main focus, or are they going to be working with prevention overall, or is their main focus going to be MSM?
This is the same position that's doing all that strategic planning policy stuff that I talked about. So they will work with, you know, across prevention, but their main focus will be on MSM and ensuring that our portfolio for MSM is appropriate and aligned, you know, correctly with the epi data. And, you know, I had to tell you guys, I was a little bit surprised. I don't know if you guys were, but I was looking at the priority populations that were just sent out. Everybody has that, right? That list of priority populations. Everybody know what I'm talking about? Oh, darn it, I had it right here in this pile. Where did it go? Oh, here it is. You know, it looks like this. Has everybody seen this? So just when I was looking at this yesterday, and it's interesting to me that of the 15 of these little blocks that are on here for the areas, 6 of them have as their top priority Black heterosexuals, and 8 of them have as their #1 priority white MSM. And I guess, I don't know why that surprised me. Maybe it's just been shifting, you know, so much over the past few years. But the funding snapshot that I think you guys have, or if you don't have it, you'll have it soon. Oh, you have it sitting right there, that's it. If you look at that, it's still pretty much the same as it was last year, where like 2% of our money go to white MSM. So it was interesting to me, it just kind of struck me that 8 areas have that as the #1 priority population. So that's the kind of thing I'm talking about, is, you know, aligning our activities, programs, strategies, and some of it might be bringing in new money. I mean, nobody's interested in taking money away from one program to put it in another program. We're certainly not going to do that. But the signs for 2012 are really good and actually getting better, that we stand to gain, you know, at least a couple, maybe a few $1 million in 2012. So, and that's because, for those of you who are new, let me take a minute, that's because CDC seems to have agreed and committed to reallocating the national portfolio of prevention funding across the country based on the epidemic, because the distribution is pretty out of whack with, you know, where the cases are. And Florida has been hurt by this. We've been chronically underfunded by CDC for, you know, as long as I've been here, years and years and years, and that's in their directly funded as well as their prevention cooperative agreement. So if we get a few million more dollars, we want to make sure that we put it in the right places. You know, so there's a lot of work to do, you know, over the next few months, and hopefully you've all seen the email that I sent out that we want comments, we want feedback. We want to do actually a series of things over the next couple of months to seek input from all of the stakeholders and partners, and of course you guys are top of the list, because we really want to know what your thoughts are, and where do you feel, if we did have some new money, where do you think it should go? What's the best way? Documents.
Marlene, I'm sorry, because there was one other thing I wanted to follow up on.
Sure, I'm sorry, go ahead.
No, that's okay. that person then, since their main drive is gonna be MSM, are you looking to fill that position with an MSM, a gay male?
That was the plan since December. We have been looking for a gay male for that position, and it is now April, and we cannot find one who will come to Tallahassee who is qualified to do that work. Literally, we have had it advertised since December, and I can't even tell you how frustrated that I am over this. So the person, well, you know, it's, somebody has to decide that the work that they want to do kind of takes precedence over your social life, I guess.
Not if you're a gay male.
So I'm afraid to say that it is going to be a woman who is probably going to be the one who's going to be put in the job, because I just can't keep having it vacant. I mean, I've just got to have somebody in it. But this woman, many of you actually know her. Those of you who've been around for a while, and she does have a lot of experience working with gay men, doing policy development, doing strategic planning, doing goal setting. So we're going to have to think about another way, and this has really kind of been on my mind a lot lately. We're going to have to think about another way to get that work done. You know, we have Lorenzo's position, who's our Black MSM coordinator, and as you may know, he's in Palm Beach. He's not in Tallahassee, because you just can't get somebody to do that work, you know, in Tallahassee. So, you know, that may be a model that we have to go to, where our office coordinates, but the real, you know, brain power, the leadership, the people who do the functions are not in Tallahassee. I mean, you know, and if you guys have ideas, I mean, I put out numerous emails. If you know somebody for the position, tell them about, I mean, we begged people to apply, and, you know, zero.
You know, I mean, and I'm not knocking Tallahassee, but being a gay male and someone who's been to Tallahassee, there's not very much of a community for gay men.
Right, you're exactly right.
And I think that's one of the big problems you have, finding gay men there. Because I mean, I know there are gay men in Tallahassee, but I think that's a big issue. That's your biggest issue and problem. So I wholeheartedly agree with the program, or with your assessment of saying that maybe we need not to have them housed in Tallahassee.
Yeah.
And I would like to point out that most of the brain power has never been in Tallahassee.
Thanks, Bobby.
That's the brain
power.
power.
Nice guy.
I'm not talking about the Bureau, I'm just talking about
So we're open to those other, you know, types of options, because I mean, I just don't know how many times I can keep re-advertising it, and you know, for months. I mean, we're at a critical point. This grant is going to be due in a couple of months, and you know, we got to have the people on board. Ken?
Where are you advertising that?
Well, all the positions go out on the internet. It goes out through NASDAD and some other national listservs. It's gone out to all of our, you know, these types of groups, you know, HAPCs, EICs, PTCs, contract managers, RMACs, Gay Men Advisory Group. You know, we have our work groups through there. You know, I mean, we, you know, begged people, you know, please consider this, please come. And, you know, it's, you know, I get it. I mean, I know what all the reasons are. And the salary is not like we can really convince somebody to come because the salary is so amazing, because it's not. I mean, it pays $40,000 a year. I mean, who's going to give up their life and their home in Fort Lauderdale or South Beach or Orlando to come to Tallahassee and coordinate, you know, this massive job? Because, you know, anything with HIV in Florida is a massive job, you know, for that kind of money.
It's got to be a woman.
Yeah, well, there you go. That's it. Yes, ma'am.
If I may ask, how is it then that Lorenzo was able to hold that position and stay in West Palm, but we weren't able to maneuver this position you're talking about for someone to stay in another area and still do it? Why do they have to be housed if Lorenzo is in West Palm and able to do the same thing?
Yeah, well, because I think this position's a little bit different. I mean, you know, we don't really have the day-to-day contact with Lorenzo. I mean, he does his set functions. He's also an RMAC. He's a contract manager. He has a lot of other, you know, functions that he does. That's one hat that he wears, is to kind of help us in those efforts. But this really needs to be full-time. They need to be at the meetings in Tallahassee. They need to be in the leadership meetings because it's just so high level and important. So, you know, maybe that can be kind of the coordinating function, but the advisors, so to speak, can be these other people that are stationed, you know, elsewhere. I mean, I don't know. We're open to, you know, creative ideas. And so with the cooperative agreement, back to that, you know, documents like this one, for example, which says Partnership for Change, Florida Black Leaders Advisory Group Response to the National HIV/AIDS Strategy. These types of documents are super helpful to us. And we had a call with the Latino Advisory Group yesterday, and we asked them to produce something similar. They have a much larger document, it's like 51 pages with their kind of strategic plan. But something that's boiled down, that's kind of bullet points, that is, you know, kind of a list of action items that we can wrap our head around, build into the grant, turn into something, you know, is really, really helpful for us. So there are other documents like this one, that NASDAD does amazing work, and they put out, you know, lots of policy type documents. This is Through Our Eyes, Promoting Health and Social Equity to Address HIV/AIDS Among Latino Gay Men. This just came out. I haven't even actually read it yet, so I brought it with me. So we look at all of these documents, you know, all of these, you know, the roadmaps that everybody puts out. And so I think, you know, to have a person who can really spend, you know, hours and hours each week pouring through these recommendations and documents and figuring out how to help us turn that into programs and policies and funding announcements and things like that is just something that we need, because it's you know, it's hard to keep up. You know, there's just a lot, you know, a lot going on. So, okay, there's all that. Let's see. The HP contracts, let me just mention that real quick. The HIV prevention contracts. You know, now we have 3-year contracts, right, and those have been very problematic for us. So you're just saying 1-year contracts, but they can be renewed for up to, you know, 5 years total.
But they're non-competitive.
Yeah, right. You compete once.
Okay. Right.
Okay.
Right.
Yeah, exactly. But it's like closing.
I think
the
that's
gap.
what everybody was saying.
Yeah. No, sorry if that wasn't clear. I mean, it's like closing the gap. You know, you compete, but then you get a 1-year contract, and then you just get another one, then another one. You know, until it's over. Yeah, be like that. Okay, so let's see. Oh, BERTA Alerta. We're so excited about. I love BERTA. Business response to AIDS, labor response to AIDS. As part of our effort to do more scalable things in prevention, we're really spending a lot of energy now working on structural interventions and community level interventions, doing kind of prevention in a different way from the way we've always done it. I mean, we know prevention is done on the ground, obviously, by health departments and CBOs, but there's a lot of bigger picture things that need to get done, structural interventions, working with schools, working with businesses, working with the faith community, you know, all of those sort of big picture interventions, and we've really moved very heavily in that direction. And April's team in particular is her whole team really focuses on those types of things. Mobilization, for example, is a big part of what they do. Media is another big part. Business response to AIDS. So in addition to supporting the local business response to AIDS or BERTA projects, what we're trying to do now is really to cultivate some statewide partnerships with companies that are either statewide or national. So, for example, we had a meeting with Walgreens just this week, and Walgreens is really turning out to be an amazing partner for us in HIV. So some of you probably have figured that out already at the local level. We have had our Baby Our Express program with Walgreens now for about 3 years. And, you know, I want to take a minute to talk about that, because I love that program too. The Baby Our Express program, for those of you who don't know, we had a problem in our state because mom would be pregnant and HIV infected, And she would do all the right things. She would go to all the doctor visits, take her medication, have the AZT drip, maybe have a C-section, you know, do all the right things. Then she would get out of the hospital and the doctor would say, you need to go fill this prescription and get 6 weeks of medication for your baby, the AZT syrup. Well, that's where things would break down in many cases because mom couldn't afford to go and get that prescription filled. So we actually had babies who were infected, became infected because of that. And, you know, when we learned this was happening, you know, we all just fell off our chairs. I mean, that's so unconscionable. You know, the drugs cost like $30 or $40, depending on, you know, the baby's weight. So we entered into an agreement with Walgreens, where they provide vouchers to the nurses in the different counties who, if there's a mom who can't afford the med, then she can go and take that voucher to Walgreens and get it for free, because we pay for it up here, kind of behind the scenes. So we've had that for about 3 years, and this year we won a Davis Productivity Award, just saying. And let's see, we provided AZT to 129 babies in 2010. So think about that. That's 129 exposed babies who, without this medicine, some of them, no doubt, we will never know how many, but some of them could have went on to actually become infected. That whole program cost $3,648, basically less than $29 per baby is what it cost us, right? Yeah, that's one of my favorites. So Walgreens has been a really good partner. They're partnering at the federal level. They're a partner on Greater Than AIDS. They're going to be a partner on eChip, doing some things in Miami, which we don't know all those details yet. So we met with them, and we just, you know, made this list up of like kind of pie in the sky things. Like, wouldn't it be cool if, you know, kind of a list. And so we sent them that by email, our list, and he took it, this guy John McGuirk, he took it back to his leadership. And some of you may know him, Miami people should probably know him. And surprisingly, they thought these were all really good ideas. And so we met with him this week and we were like shocked. He was like, yeah, they thought that was a good idea. And we were like, what? You know, when you just like throw something out there and you're just like, there's no way. And some of the things that we had, they're already doing. Like, for example, we thought it would be neat if for HIV patients who were late in picking up their meds, if they had like an alert so that they can follow those patients, you know, call them, contact them, try to get them to come in. And so it turns out that in their centers of excellence, which are stores that have specific emphasis on HIV in high incidence areas, that they're already doing that. So we asked if that can be expanded to other areas. So they thought they liked that. We asked, could messaging around HIV be included on the pharmacy bags that people get when they pick up their meds? Could there be something on the back of the receipt? Could there be a coupon that prints out that maybe says, take this to United Deliverance and get a free HIV test? And they're open to that. We talked about partnering on community testing events. You know, would they host health fairs in their parking lots and cook food for people? If we provided the screenings, you know, would they host it, advertise it, promote it, and cook food? And they said yes, they're open to doing that. One of the cool things we thought of is that, you know, you hear that sometimes people are leery of government condoms, like what they call, you know, government condoms. There are some people who don't want to take condoms from DOH. So we thought, what if we gave Walgreens some money and then we gave vouchers to you all to give to clients who take a test or do an intervention or who do something, and then they took that voucher and then they go into Walgreens and they get a free box of any kind of condoms that they want, and then, you know, we pay Walgreens kind of behind the scenes to, you know, provide that. And they were really open to that. So, and there's other, employee wellness, you know, we talked about that. They're very open to that. Putting messages on their websites, in-store signage, the red leaderboards that they have out on the street, promoting observance days on those. You know, this whole long list of things they were really open to. So if you guys have Walgreens in your communities, I just want you to be aware that, you know, they are very willing to partner with us. Yes, ma'am?
How does the, medication alert work?
What they told us is that if somebody's late picking up their meds, they will try to contact them up to 4 times. They'll call them. I don't have all of those notes with me. Those are in my notes, I think, back at my office. I think they said that after 4 attempts of contacting the person, then they notify the physician that that patient hasn't picked up their meds.
So when they actually talk to the person over the phone, do they just say, you just come pick up your meds?
Yeah, and they don't say what it is, you know, obviously, it's just, you know, you have a prescription waiting to be picked up at Walgreens, please come in and get it, you know, that kind of thing. I don't know who's first. Ladies first?
Well, I just wanted to say that those of us who have worked in the nonprofit sector as well as bureaucracy know that nothing will happen if you don't ask.
Yeah.
That was brilliant to ask, to just put it out there, like I said. That is great, and I was so pleased because at our last BCPP meeting, there was a rep from Walgreens. Now, years ago, when we started prevention planning, they would come, but I don't know what happened. They stopped coming. But I was so happy to see this gentleman at our meeting from Walgreens, and that's just absolutely wonderful because I think they're one of the most, one of the busiest pharmacists in Florida.
Yeah, they said they estimate that they have probably about 10,000 HIV/AIDS patients who use their pharmacies statewide. There's 889 Walgreens pharmacies in Florida. There's 120 in Miami-Dade County alone. They open a new Walgreens every 16 hours. I sound like a commercial, right? I'm a fan now. I was impressed. I mean, you're right, you have to ask.
You do.
Yes, ma'am.
I do want to note on piggybacking the Walgreens in Orlando, we have, Hope Health has gone to provide testing. We had one of our board members inquire with the Walgreens corporate office there, and we've sporadically gone to several Walgreens, parked our mobile unit out in the parking lot to provide testing.
Awesome.
They were open to it. They just supposedly send out their email to their local locations and tell them that we're coming. We did have a couple of instances where one Walgreens does all the advertising. They're going to be here this day, blah, blah, blah. Some of the other Walgreens didn't do the advertising. So, you know, we're trying to tweak that to let them know that they need to let people know in the, you know, neighborhood that we're coming that day. If we have to come out, that'd be fine, but I think they were supposed to do that. So we did run into some instances where the Walgreens store manager, people didn't let people know we're coming. We sat there for 4 hours and nobody actually came onto the bus. And then you have the ones that did let people know and we were testing them. So Walgreens will do that. So if anybody in their area want to try to do the same thing, but we did use the mobile unit because they didn't have a space on the inside for rapid testing.
Yeah, and I think a lot of that, you know, an individual store manager can make a huge difference. So what we're doing, we're going to actually sign an MOA, that's our plan, with corporate headquarters. Their headquarters is in Chicago. We're going to sign an MOA with Walgreens where they actually spell out, we will do blah, 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 and, you know, Department of Health will do whatever. So this way then the regional, there's Walgreens in Florida is broken into 3 regions. There's kind of the northeast part of the state, northwest, and then south. And so each of those regional managers will then get that information. We have an MOA, here's what we're doing. Then they can filter that down to every single store manager. And if there's a manager who's not on board, then it can go back up the chain and they can say, you know, we have an MOA, you know, you need to get on board with this. So we're going to try to help you with those things. Bobby?
Until that actually occurs, could you send us that list and who you've got as a contact? So if we go to a Walgreens and say, the guy says, we don't do that, we could say, you need to call whatever the guy's name is in Miami, and see how he's doing it, or something like that? Can you?
Yeah, as soon as this list gets finalized, because right now these are just like working notes, and he had to take some things back up his chain. So the minute we get this finalized, we're going to try to meet again the first week of May. We want to move this very quickly and try to have an MOA in place by the end of September is kind of what, what we were shooting for, because the review process and the lawyers will, take a little while. So the minute we have something that we can release, we will absolutely send it to everybody with contact information of, this is the guy to call if there's a problem.
Thank you.
Oh, wait, I'm sorry, I think, no, I already did.
One more question. Are you allowed to work with other businesses such like Walmart, CVS?
Yeah, that's our plan. We'll work with anybody, if somebody wants to be a partner with us, we will work with anybody and everybody. So we're just trying to pick them off kind of one at a time. But that's really sort of the model that we want to move to. So we had to build the team, we had to build April's team up to create the team and then have her hire staff so that we have bodies, because this takes a lot of energy to do these kind of statewide, agreements. So that's our plan, is to keep doing that with different businesses, yes. Any more questions? Oh, Bobby, sorry.
I would like to point out that this is not a hard project to get going in your communities in rural North Central Florida where we are. We've got like 69 organizations, everything from fish markets to hair salons. The business community is willing to partner up to do this. I mean, some of them will put signs in the windows, some won't, some will take condoms, some won't. You just have to be willing to do what the business leader wants to do. Some places let us come in and do testing. It depends on, we offer them a menu. So choose what you want off this menu, and we'll do whatever it is you want. It does mean that you have to be able to get the condoms to the people on a regular basis, which may mean building a volunteer network depending on how far you gotta go. You have to show up when you say you're going to do testing. You have to give them fresh signs to put in. But the business community, you'll get rejections. Yeah, none of my customers have sex. Okay.
Yeah. If only.
Yeah, at least not in my store. You just don't know about it. So, I mean, it's a project that once you start with it, it rolls along pretty good.
We had two things. John McGurk is actually one of the.
Yeah, that's who we met with.
He's actually one of the founders of SOBAP as well, from many years ago. Just so you'll know that when you're talking to him, so that's why he has a real passion for working with.
He really does, and he was out of the business for a little bit and then came back, and he's quite impressive actually, quite impressive credentials. John, was it you? Somebody?
Yeah, I had something.
Oh,
Now, going back to Walgreens, and Walgreens, the stores are not the only ones that'll work with you. They do have local reps that go around to different agencies, and they're inclined to work at any level. Whatever event you have, they'll open their pockets. And I'm one that every time I see a rep, they run for me because I'm always put my hand out. So they're willing to give you anything and everything.
Awesome.
So at anything, you don't only have to go to the stores to get your testing. For any event that you have, just look for something that we
The other thing that they have that's kind of cool is they have these specialty pharmacies. There's another name for them, but they're in either hospitals or outpatient clinics attached to hospitals. And they're not like a traditional Walgreens. They don't have like the front end side of it. They don't have the Coca-Cola and potato chips and aspirins and all that, but they're a pharmacy. And because they're in hospitals or clinics, we're exploring, how can we take advantage of that? How can we leverage some of those relationships, for example, to get testing in the emergency room? Because, and they're willing, we actually have that conversation, they're willing to try to help broker some of those conversations for us because they're established in a hospital, and there's some hospitals that are very stubborn that just won't come on board with testing, particularly in their emergency rooms. Very, very frustrating. Like Palm Beach comes to mind, very frustrating place. So they have inroads. They're in St. Mary's, they're in Good Sam. So anything we could get, to get these ERs to come on board, we'll take. So I want to talk about eChip for the last thing. And ECHIP stands for Enhanced Comprehensive HIV Prevention Plan, ECHPP. And I don't usually use slides when I talk to you guys. I want to be more informal, but there's so much information, and you guys will get all of this, so you have to write it all down. Anyway, what ECHIP is a really different way of doing prevention. It really takes us to a sort of a big picture way of thinking about an epidemic in a city, attacking it through a variety of these interventions. They prescribed the required and recommended interventions, and then so everybody, all of the 12 cities that are funded have to do all of the 14 required interventions, and then there's some recommended interventions that you can, pick or choose from depending on your needs. So in Miami, we are doing all of these required interventions. So the first one, routine opt-out screening for HIV in clinical settings. And I know that there's not time to go into this, but at some point, when our plan is completely finalized, the ECHIP, the plan itself, we will send that to all of you, so you'll all have the plan. But each of these interventions have goals and strategies around them. And they have epi-data and rationale and a bunch of other stuff. So this is just to give you a flavor, and it's important even for those of you who aren't in Miami to understand this, because we're thinking that CDC is going to borrow very heavily from ECHIP when they do our prevention cooperative agreement for 2012. So we could be looking at a model for the whole state that looks like this. So the second one, HIV testing in non-clinical settings to identify undiagnosed infection. Then there's condom distribution, prioritized to target HIV-infected persons and persons at highest risk. We have a huge condom program in Florida, but it's not great, and it's not great in that we can't evaluate it. There's no data around it. And so that's been something that we've been working to fix for the last year or two. We want condom distribution to become a structural intervention, not just let's send thousands and thousands of them out and then never find out what happens to them or where they go, which is how it is now. Number 4 has to do with PEP, provision of post-exposure prophylaxis to populations at greatest risk. Number 5 is about these structural interventions that I talked about, trying to change existing structures, policies, and regulations that are barriers to creating an environment optimal for prevention, care, and treatment. Number 6 is implementing linkage to care, treatment, and prevention for those who are infected, and really focusing on people who are infected but not in care, because we still have, unfortunately, lots of people in that category. Number 7 is about implementing interventions or strategies promoting retention in or re-engagement in care for HIV-infected persons. Number 8 has to do with following the guidelines. You would think this would be a no-brainer, but man, you'd be surprised. We really need to make sure that medication is prescribed accordingly. Treating HIV is hard. Not everybody could or should do it. So lots of energy needs to be put there. Implementing interventions or strategies promoting adherence to antiretroviral medication. This is a big issue too. Adherence is a problem. And the ADAP crisis does not help. When patients are uncertain about if they're getting their meds from day to day, where do you pick them up? You get them here one week and they're the next week, and oh, now you're back over here, now you have part of it. And that none of that is good for adherence and continuity of care. So that's one thing that's sort of the elephant in the room that has to get fixed for us to be able to do a lot of what we want to do here in prevention, because treatment, as you all know, is prevention. If we could keep folks in care on meds and undetectable, we'd have a lot less transmissions. Then number 10 is about STD screening, implementing STD screening according to current guidelines for HIV-infected persons. And this is really important too. Even though the report card I think is pretty good from what we hear from chart reviews when AETC goes out and chart reviews, you know, we hear that the report card's pretty good, but I think that there's probably more that can be done there. Number 11 is implementing prevention of perinatal transmission. We are still having transmissions, even though it's, you know, greatly reduced from where it's been. In 2010, I think the final number is either going to be 4 or 5. We had one in 11 already. We had another baby in Leon County, where Tallahassee is. We've had 3 infected babies in 3 years in Leon. This is a 911. We have declared that this is a 911. We will be doing lots of community meetings with doctors, very intensive work in Leon County. That's unacceptable. It comes out when you look at the exposed women, that's about a 9% transmission rate. And Miami's like less than 1%. So that's, you know, none of that is okay. Yes, sorry.
Do you know if those transmissions were persons that were previously positive?
Some were.
Yeah, that's our biggest problem in Area 12, identifying pregnant previously positive, because they don't automatically, the lab work isn't automatic because they're already positive. So it's those persons that we get late in pregnancy. So we've got to somehow find a way to identify previous positives that become pregnant.
Yeah.
The new positive is not an issue with because there's that automatic testing.
Gotcha. Yeah, that's a great point. There's a move that's brand new at the national level, and some states are moving forward with this. We haven't yet, but there's a recommendation to make HIV infection and pregnancy together a reportable condition.
Okay, I didn't understand that, what you were saying. Could you explain that just a little bit more? I mean,
if a person is newly positive, based on the laws here, they're going to be tested if they're pregnant. Their test is going to be offered the first trimester and the third trimester.
Now, if they're newly positive, they're tested to see if they're pregnant?
Well, if they're pregnant, they're going to be tested twice during that pregnancy, the first trimester and the third trimester.
Okay.
For persons that already have an HIV positive status, they're not going to run that test because the status is known. So we in the local area are not finding out that those persons are pregnant unless somebody eyeballs them on the street, one of the other agencies, or that they present at labor and delivery, and they'll test them then.
But theoretically, if that mom has disclosed to the doctor, yeah, I know I'm infected, then she should be getting all the arms of the protocol, and then the baby's chances of being infected should be reduced. So, you know, but some are falling through the cracks, is what you're saying.
Yes.
Nice.
Quick question. As far as with the child that was positive, was the mother actually receiving prenatal care?
There, you know, I don't know all the stories of them. Nita knows them all. The newest one is still being investigated, so we don't have all the information, but I know the newest one, she had 7 prenatal care visits on her. She was tested at her initial visit. She was a known positive, just like what you're saying. Known positive since 2004. Her first prenatal visit, she tested positive for chlamydia, gonorrhea, herpes, and maybe one other. At birth, she tested positive for Hep B. And then I don't know all of the details on, you know, why the baby ended up being infected. I don't know if it was a compliance issue or what. We're still investigating. So there's a variety of issues. Bobby?
I would like to jump back to a pet peeve of mine. On number 1 back up here, I don't want to abandon pregnant women. I know it's an important topic, but
Number 1, you said?
Yeah.
Okay.
Routine opt-out screening for HIV in clinical settings.
Yep.
I know we're pushing the community to do this, but I think we do a horrible job in public health doing this. I think before we're going to convince the community to do this, we need to be doing it in our own community, our own health departments. We do a pretty good job in STD and in anonymous counseling and testing and some other places like maternity or family planning. But when it comes to primary care, which is where we're really trying to get the rest of the community to do it, when you look at those numbers, they don't test much, but when they do, they find a lot of positives. At least in our area, there's a high percentage of positivity rate, but we can't get them to test.
Yeah.
So if we could get some push from the top to the health department saying, hey, look, this is our statewide data. Only 4% of the tests that we do across the state is happening in primary care, but our positivity is 3.5% in primary care. We need more testing there. It seems like a good place to get it. This is a recommendation since 2006.
Yep. We can take a look at the data. My guess from when I've looked at the data is that if you look at the new positivity rate in that setting, it's probably less than 1%. I think that those high percentage rates are the known positives that are coming in, the proof of positivity, or they're coming into HIV.
What we've done to solve that in our area is we have a separate number. If you're coming in for proof of positivity and you just need it for clinic, you're coming from New York or Ohio, wherever you're coming from.
Right, you guys have a separate.
We just put a separate number in, and that's not hard for you guys to do up there, to put a separate number in. It's maybe hard to convince people to use it.
Right.
But even so, we still need to be testing if we're going to try. If I go to my community and say, I want you to test to my private physician, I think you got to be testing in your practice. He says, well, how successful are you at the health department?
Yeah.
We don't do it.
Right. Okay. Well, that's a good point, and the legislature wants to defund primary care in the health departments.
I understand that.
So there may be a lot less. But that's an excellent point. I think we left off on number 12, implement ongoing partner services, and that's, a no-brainer, near and dear to my heart. Partner services works. It's the best way to find new positives. Behavioral risk screening followed by risk reduction interventions for infected persons. Number 14, linkage to other medical and social services for HIV infected persons. And then, so those are all of the required ones. So all of those 14 are the ones that all 12 of the cities have to do, required. Then the one that we picked, the recommended one that Miami picked, was number 24, which is community mobilization to create environments that support prevention by involving community members to raise awareness, building support, involvement in prevention efforts, motivating individuals to end stigma. That was a big one for us. We want to continue our work around stigma. We really wanted to continue our mobilization around SOS, Out in the Open, Man Up, all the mobilization activities, VERTA, Faith, and then Test Miami, of course, is a big part of the E-CHIP plan, so that will continue. And then finally, I wasn't gonna, this was in an email that I sent to Tom, and he made me put this on the slide, Tom Liberty, to share this with you guys. This, I sent an email to Tom Liberty and Lillian Rivera, the director of the Miami-Dade County Health Department, because I was really proud of the work that the E-CHIP team did. And these were the comments that we got back. There was a federal review team who approved our E-CHIP. It was 5 people from CDC, HRSA, SAMHSA, and then some other federal, they don't tell us who all the reviewers are, but all federal partners. And so these are just some of the comments that they said about the E-CHIP. And so Tom wanted me to share that with you because he was really proud of this work. And the last one, I think, is my favorite one, saying that we've gone well above and beyond expectations in producing an exemplary plan. The other cities that are part of the 12 cities are really like the granddaddy cities, New York and San Francisco and LA and Chicago, DC, all the big cities that have way more money than we do. And so this was our plan, being looked at in comparison to all of theirs. So I thought that was pretty cool.
Marlene, I have a question regarding the E-CHIP.
Yep.
My question is, does E-CHIP mandate the necessity of PPG sites? And if anyone is not familiar with PPG sites, they're program collaboration services integration. And pretty much what it does is align the public health policies with public health activities. And I wanted to know, does this plan particularly going to include PPG sites, or how's that going to work?
Yeah, that's an interesting term. I haven't heard the term PPG sites before. I think you're just really talking about sites that provide integrated services. So yeah, there's definitely an emphasis on integration, one-stop shopping. The more that if a person can go to one place and get their hepatitis vaccines and their HIV STD tests and pick up their meds and the more likely people are to come. So there is definitely an emphasis on that. That is scattered all throughout the plan. And, you know, I think that that's something that we don't do enough of. And some of it is because of the way the funding is structured from the feds. Even though the feds talk about Pixie all the time, they don't act Pixie-like. And that has been my biggest frustration with them, is you can talk the talk, but until you've integrated at the federal level, where your people are talking to each other and your data systems talk to each other, don't mandate us to do it, you know, as an unfunded mandate when they haven't done it yet. So I think that's why some areas have been slow to really try to push it, because of the funding silos and data silos.
Okay, well, I was just at a capacity building forum in Nevada, and there is a site in Hawaii that is very successful in deploying the Pixie program. So I was just curious as to was that going to be implemented here, or how is that going to work in relation to the future plan?
Could we ask her to identify yourself?
Oh, you want me to identify?
Please. For the record, and for us.
For the record, my name is Crystal Payne, HIV Prevention Contract Manager, Area 9, Palm Beach County Health Department.
And then explain what Pixie is again.
It's the Program Collaboration Services Integration.
Okay.
And Marlene was just pretty much saying how it's like one-stop shop. But there is in Hawaii program that's doing it, and it seemed to be very, I think it's a pilot program still. I don't think they have it all together, but I was just curious to see if it's something that Florida would be interested in partaking in.
Yeah, and I mean, CDC actually put out some funding for Pixie not that long ago, and we looked at it, and for a number of reasons that I won't get into, we decided not to apply for it. It was just really poorly structured and thought out. So some of those states, maybe Hawaii's one of them, maybe they got that funding to do that, I don't know. But we try to be Pixie-like whenever we can. I mean, we try to integrate. When we go into jails and we have our counseling and testing and linkage programs, we try to piggyback STD testing, hepatitis testing, hepatitis vaccinations. When we do outreach, when we have lots of mobile vans, you know, all over the state that offer a variety of services. And not even just with the HIV, STD, Hep, which are the most common ones that get talked about, but blood pressure screening, diabetes screening, you know, integrating so that you have a health and wellness type program, and HIV is one component of that. And I think, you know, if that's the way we can move to with some of our programs, where you're really looking at it, you're looking at the person as a whole person, not just as, you know, one component of that person. They have sex. We need to do their HIV test. And then they got to go over here. Oh, they eat a lot of donuts in the morning. Better test them for diabetes. And, you know, people are people. They're not just, you know, they don't fall into those neat little boxes. So I think that's what we're trying to consider through, you know, as we move our prevention programs forward, is to have more of a holistic approach. And like with the Walgreens, you go in there to pick up your meds, and you may be able to walk out in the parking lot and get blood pressure, diabetes, cholesterol, and HIV testing, and then still make it to the daycare to pick up your kids on the way home. Naya?
I was just gonna say, I know the Leon County mobile unit, it is actually a one-stop shop. The nurse, she does pregnancy, STD, blood pressure, what's the other one?
Yeah, the diabetes.
She does all of it, and then once they leave, they get trauma and all that kind of stuff. I want to say she spends at least an hour with the person doing all of that.
There's a lot of models like that. You know, our community health centers, we contract with several of them under EDDI, the Expanded Testing Initiative, and there's a lot of them that go out with these great, huge mobile units, Borinquen, Healthcare Center for the Homeless in Orlando. There's a bunch of them that I can think of that really are. I mean, some of them have, you know, exam tables. They do pelvics, they do all kinds. You feel like you're in your doctor's office. But we actually have quite a lot of that in Florida already. And the more the better. I mean, would we agree? Shane?
Marlene, is there any work being done with like Healthy Start that does prenatal care to incorporate HIV testing and all that stuff?
Yeah, Nita Harrell, who's our perinatal coordinator, she works really closely with Healthy Start. They've been a partner of ours for a long time. They have suffered a lot of budget cuts recently. they used to be one of the few people that did outreach, you know, that they would actually go into people's homes, you know, even before TAPWA, you know, the Healthy Start workers would go out and they would do the screenings for the moms and the babies. And I think some of that is in place, but, you know, I think with their budget cuts, I think that they're having a hard time keeping up with their caseloads, but I know that that's part of what they do, is to try to make sure that the moms have been screened, that they're getting prenatal care, that, you know, I mean, that is a part of what they do. Yeah, they're a good partner. Any other questions for me, comments, thoughts? I'll be here the whole next 2 days, so if you think of anything else.
Thank you, Marlene.
Yeah, thank you.